Our sports injury project is on ulnar collateral ligament, specifically Tommy John surgery. And our focus is on grade 3, which is a complete tear. Basic pathoanatomy and physiology. The UCL has three parts, and the most important part for throwing is the anterior bundle, which provides 50 to 60% of the elbow's resistance to valgus stress, and is the primary stabilizer during throwing. There's also the posterior bundle, which is the second stabilizer, and this helps throwing during higher elbow flexion angles. And there's also the transverse bundle, and this is a minimal functional role, and it provides little stability. The location of the UCL is on the inner side of the elbow, running from the medial epicondyle of the humerus to the coronoid process and olecranon of the ulna. And the function of the UCL is to prevent the elbow from opening up on the inside. And during the acceleration phase of throwing, the arm is constantly rotating, and over time, the anterior bundle just goes under a lot of stress, specifically valgus stress. The pathology is from overuse of repetitive throwing, and the main cause of UCL tears is in baseball, and this is caused when the elbow is pushed inward while the forearm is pulled outward, and it could also happen from sudden trauma. And the ligament's ability to stabilize the elbow is compromised, which leads to pain, decreased ability to throw, fatigue, and sensation of instability. There are three grades of injury. We're focusing on grade 3, which is when the ligament is completely torn. And the key symptoms are medial elbow pain, loss of throwing velocity, instability, or giving out, or just any popping sensation. And studies shows that 13% of MLB players and 35.3 of MLB pitchers have had the procedure at some point, and this frequency is currently rising. Mechanisms. The primary mechanism of injury, which is the most common, is repetitive valgus stress during overhead throwing. And this is most common in baseball players. And then we have secondary mechanisms, which these are less common, which is the acute pop during a single pitch, and then also just traumatic valgus force. This is more rare, like falling out on an outstretched arm, or trying to, like, a direct hit to the lateral elbow, or any hyperextension. And then secondary contributors, which are not primary causes, are increased stress on the UCL, medial elbow flexor fatigue, and shoulder internal rotation. And then we have surgical mechanisms. The first one is incision and removal, when the surgeon makes typically 3 to 4 inches on the inner elbow and removes the damaged ligament. And then for graft harvesting, if there's not enough healthy tissue, then they need to use a graft. And some of these can be the palmaris longus tendon in the forearm, the gracilis tendon in the inner thigh, or the extensor tendon from the big toe. You could also use a cadaver tendon, and then the surgeon has to drill tunnels by the humerus and ulna to anchor the tendon. And then the graft replacement, the surgeon places the tunnels to make sure the graft can be woven in place. And then securing the graft, they use a docking method, and then they have to close the incision and make it immobilized.
So the post-surgery process occurs in two phases. The first phase is weeks 1 to 3 post-surgery, and it's the period of immobilization where the elbow is placed in a brace to hold the graft in place. And during this phase, patients will focus on reducing pain, swelling, with medication, icing, and elevation. And during this time, small range of motion exercises are done to enhance hand, wrist, and shoulder mobility. Phase 2 is week 6 to 12 post-op, and during this phase, the brace is removed and patients are transformed to a splint, allowing for more mobility. From here, rehabilitation focuses on increasing range of motion by strengthening the elbow, forearm, and shoulder, and then through this goal, the phase is to regain full shoulder extension. And for athletes, 3 to 6 months post-op, therapy is progressed to return to sport. The differential diagnoses are common misdiagnosed injuries, which include flexor pronator strains, cubital tunnel syndrome, elbow tendonitis, osteochondral lesions, valgus extension overload syndrome, and a fracture. And these are all due to similar symptoms of UCL tear, which occurs on the linear side of the elbow, which is caused by a popping or numbness sensation or tingling down the fingers. To rule out this injury, medical professionals will perform evaluations assessing the range of motion and strength. Doctors will use a history and symptom analysis to distinguish the specific injury. And then, with the use of imaging such as ultrasound, MRI, and CT scans, doctors can look for ligament and tendon damage. When a patient undergoes an evaluation, normal observations include mild swelling and tenderness over the medial aspect of the elbow, significant tenderness over the UCL attachment points, which occur on the medial epicondyle of the ulna. As for range of motion, near normal range of motion, active and passive is seen. However, a loss of elbow extension and painful sensation while testing occurs, especially during a valgus stress. And for instability, it's just a loose or wobbly feeling or sensation. A typical mechanism includes I felt sharp pain on the inside of my elbow after a hard throw, and then pain occurs during a cocking motion and an acceleration phase of throwing. Common statements include my velocity dropped and I can't throw as forcefully. I feel unstable when I throw. I get tingling down into my ring and pinky fingers after I throw. Rest helps, but when I throw again, I feel severe pain. Some special tests with their outcomes include a valgus stress test, which the outcome is pain and laxity compared to the opposite side, the milking maneuver, which is reproduction of the medial elbow pain, moving valgus stress test, which is pain between 70 and 120 degrees of elbow flexion, and then for ultrasounds, gapping will appear during the UCL during dynamic valgus stress test, and then MRI shows an increase in detection of tears. As for neurovascular concerns, ulnar nerve irritation occurs in digits 4 and 5, which is known as the numbness sensation. And then for a special test, here's a video of the milking maneuver.
To perform this, we do this supine position pass rotation. And we're looking for medial elbow.
For MRI imaging, there's 3 images up here. A distal tear, which occurs at the bottom portion of the ligament, which is less healing potential than a proximal tear. A mid-substance tear is when the tear is in the middle of the UCL, and then a full thickness tear is when all fibers are torn.
For acute post-surgery rehab, it starts with phase 1, covers weeks 0 through 3. During this stage, the focus is on protection and gentle mobility. Patients perform shoulder, wrist, and hand isometrics with the brace on, along with passive and active assisted range of motion for the shoulder, elbow, and wrist is tolerated. The main goals are to reduce pain and inflammation, prevent muscle atrophy, and avoid any external rotation. To move on to the next phase, patients should achieve 15 to 115 degrees of range of motion and reach a 4 out of 5 on manual muscle testing. Phase 2 spans weeks 3 through 6. Here, the patient progresses to active range of motion exercises. They work on wrist flexion and extension, pronation and supination, and begin elbow flexion and extension. Light weights can be introduced gradually. The goals for this phase are to reach full range of motion by week 6, discontinue the brace, and start rebuilding strength. Progression criteria include full range of motion from 0 to 145 degrees, at least 70% strength of the wrist and shoulder, and performing exercises without pain. Here are some examples of patients performing exercises. In acute rehab, phase 3, from 6 to 12 weeks, focuses on building strength and preparing the patient for more advanced activities. Exercises during this phase include continued strengthening of the forearms and elbows, throwers 10 programs, and proprioceptive neuromuscular facilitation exercises. The main goals are to increase strength and muscular endurance, address any muscular imbalances, and begin the transition into plyometric exercises. Progression requires maintaining pain-free range of motion, achieving at least 85% strength, gradually adding heavier weights, and ensuring no pain during activity. Phase 4 spans 3 to 6 months, and this is where advanced training begins. Exercises progress to multi-joint, multi-planar strength movements, plyometrics, and eventually tossing or sport-specific activities. The goal for this phase includes redeveloping proper throwing mechanics, regaining full power and endurance, and safely integrating sport exercises. To progress, the patient must maintain pain-free range of motion, achieve over 95% external and internal rotation strength, demonstrate elbow flexion strength, and successfully complete functional tests. For return to sport, phase 5 covers this stage, which begins around 6 months post-surgery. At this point, athletes progress to the Advanced Throwers 10 program, gradually increase their throwing distance and force as tolerated, and begin game day simulation activities. The goals in this phase are to safely transition back to sport participation and to reinforce proper throwing mechanics to prevent flare-ups or re-injury. To be cleared for return to sport, the athlete must have full pain-free range of motion, be able to complete all sport-specific tasks without pain, and any soreness should stay below a 4 out of 10 and resolve within 24 hours. This is an example of a throwing progression. This is the beginning. and this is more of an advanced throwing. And this is a program followed by many baseball players during their return to sport phase. Here's how we're excited. Thanks.